Our next speaker is MARIAN PAULY. His title is Failed DCR. What do you do? Failed DCR is really a challenging case and problem.
Thank you, AIOS and Dr. Feroz, for giving me this opportunity. So, failed DCR is a big challenge in our lacrimal clinic. So, in this talk, basically, I deal with three things: what are the causes, how will you evaluate, and how will you manage. So, failed DCR can come to you even in the first week of your surgery, as early as, and the late failure can come even after 12 months. On an average, the literature says around 4 months is the failure time, and it can be either anatomical failure or a functional failure. So first we will analyze what are the causes. The most common is like fibrous tissue growth. Second, inappropriate ostium, that inappropriate in terms of size as well as in position. So inadequate osteotomy means, so from Dr. Richa we have learned, we saw what should be the size of the bone removal. So inadequate osteotomy means the bone removal that failed to expose the lacrimal sac completely, including the fundus and the proximal nasolacrimal duct. Then the position of the ostium. If you are not removing the inferior sac, it can cause later on it can lead to some syndrome. Third one is the associated common canalicular block. Then inadequate sac opening. That means like you have not marsupialized the sac properly, or the sac opening are incomplete. Some of the nasal causes, that is missing a nasal polyp and polyp obstructing the ostium. Then second is intervening ethmoids. In my lacrimal practice, this I come across very often. That is, even in the literature says, in around 46% of cases, the ethmoid is history for any systemic inflammatory diseases. Then rule out functional NLDO. That means the ostium is, patency is there, but the patient is having watering due to the pump failure that happens in occult facial nerve palsy or other causes. Then now, after ruling out the surface lead causes, look for the lacrimal patency, which we have learned from Dr. Saumya. Do a dye disappearance test and see whether the dye is draining. You can use it with the help of endoscope also, you can see. Then do a lacrimal irrigation to see whether there is a pus coming, or it is immediate regurgitation, delayed regurgitation, associated canalicular blocks, etc. Do a probing to confirm whether it is, at what level is the obstruction. Very, very important is the nasal endoscopy, why it has failed, whether any nasal causes, any granulation tissue obstructing the ostium, etc. Then in some cases you might require imaging, CT scan of the orbit with PNS, especially if you're suspecting some tumors or inflammatory causes, or even to assess the relationship of the ostium, or to assess the size of the ostium. Then dactylus cystography and lacrimal scintillography can be done, but lots of financial implications are also there. So DCG will delineate the lacrimal drainage tract, and you know the exact site and nature of the obstruction. So these are some of the high-risk factors. Especially when you operate on a small sac, small sac opening is high risk for failure. Then a prolonged surgery induces more of inflammation, can lead to fibrosis. Then when you're operating in an active phase, active inflammation also can cause a high risk for failure. Then inadequate flaps. And the important thing is intraoperative orbital fat prolapse. If you see a fat coming out to the ostium, just cauterize it or excise it. And finally, thermal damage if you're using too much of cautery to the ostium. So how will you manage? Once you are confirmed it's a failed DCR and no associated canalicular or punctal or other functional causes, you have to revise the DCR. Either it can be done either externally or endoscopic approach. So few tips when you revise external DCR, you can use the same skin incision. And sometimes, like majority of the surgeons will not cut the anterior limb of medial tendon. So most of the time that area will be fully scarred, and to get good exposure, you can cut the anterior limb of medial tendon. Then identify the original edges of the original rhinostomy. Then do free the periosteum all around for 4 mm. Osteotomy done to expose the virgin nasal mucosa. Then identify the lacrimal sac and make the flap. Here, the whole area will be fibrous, so you put a Bowman's probe in the upper canaliculus and lower canaliculus, and incision should be very careful. You should not injure the canaliculus. Then after making the flap, keep the flap under tension and suture. Otherwise, again it can cause closure. Then there are so many adjunctive measures. You can use mitomycin C. Either you can inject locally or you can topical application. For 3 minutes, some people use it for 5 minutes. That is surgeon preference. The advantage is large ostium and high success rate. Silicone intubation is little controversial because some of the authors say it induces granulation tissue formation, can induce infection. In my experience, if you remove it, like I remove it 3 to 4 weeks time, usually will not cause any problems, and it is very, very beneficial if there is an associated common canalicular block. Then trephination, if there's a distal canalicular block, you can use a trephine to remove the fibrous tissue. Then balloon dacryoplasty. So here comes the internal ostium stenosis. So what do you mean by internal ostium stenosis? There is a minimal dye passage through ostium on irrigation observed with endoscope and resistance on irrigation. In that case, you can use Lagrica catheter to enlarge. So to conclude, failed DCR is always a big challenge. A careful evaluation can give you very good results, and the patients will be very thankful if you do a great job. Thank you so much.